name's Professor John Pepper. I'm a cardiac surgeon, but currently I'm Director of Clinical Research. So I'm in charge of the research aspects of, well, overall really, all the clinical research, but particularly the research aspects of structural heart disease, which is everything to do with valves and aortas. I was invited to join the Trust in October 1990, so I moved from St George's Hospital, where I set up a heart transplant unit in 1986, and I joined Professor Yacoub at the end of 1990, just a few months before the move to Sydney Street into the new buildings. I think in the time we've been here, so the number of transplants has reduced. Some weekends 5 heart transplants would be done. A large number of heart-lung transplants were done, and now that's a very unusual operation. But the results have improved, so now 1 year survival is 90%, 5 years survival is around about 70%, which is at least 20% better than it was in the early 1990s. We've also seen the growth of mechanical circulatory support, so in other words, ventricular assist devices, most commonly the left ventricular assist device. There's been a massive increase in that activity. Associated with that more recently, a big increase in ECMO activity, which is extracorporeal membrane oxygenation to support the lungs, and if it's combined with a pump, then it's like being on a heart-lung machine. Although it has been around a very long time, since the 1970s, it was quite dangerous at that time. Now, with many technological changes, it's become a much safer and more effective system. And certainly in the last 5 years, it has really taken off in Europe. And here, in this trust, we are now the only major funded adult ECMO centre in the country. So those are some surgical changes. On the other side, of course, there's been dramatic improvement in imaging. We have state-of-the-art imaging here. We have fantastic magnetic resonance imaging, a very, very good cardiac CT scan and respiratory CT scan, and we also have state-of-the-art echo. And this has transformed, speaking as a surgeon, this has transformed surgery. When I was a trainee, I would say a third of the time, when we came to the operation, the preoperative diagnosis was not completely correct, it was inaccurate. Now we have the diagnosis accurate 99% of the time before a patient goes to theatre. And furthermore, not only can we be accurate about the diagnosis with these images, we also can identify at what point in the natural history the patient is. Those are, I think, the main changes that have occurred. So the whole pattern has changed and results have improved, and surgery and medicine as well, for that matter, are much safer. Patients are much safer in hospital than they were 20 years ago. But, there are still problems, and heart surgery is not like other forms of surgery. If you make a mistake or something goes wrong with a tummy operation, usually you can come back tomorrow or next week and have another go. Something goes wrong in a heart operation and you don't identify it and deal with it quickly, the patient dies. And that's what separates heart surgery from other kinds of surgery. When we're dealing with complex problems in the main pipe coming out of the heart, the aorta, part of the operation may be done by ordinary conventional surgery, and part of it by inserting a stent inside the aorta, a tube inside the aorta, and to do that we need imaging. So that's why we need a very good X-ray imaging in the same place as the operating room.
I see, so
that's why we need a hybrid theatre.
Yeah, okay.
And the other thing is that when you finish the operation, it gives you the opportunity to do a quick X-ray study to check everything is okay. So you don't have to send the patient back to the intensive care, not quite sure whether everything actually is okay. It looks all right, but you're not absolutely certain, whereas now we can be much more certain. So quality control is just very, very much better than it was even 10 years ago. Well, it's amazing. But I don't think that the current NHS funding is going to be spent on this sort of thing. Their priority is not this kind of high-tech medicine surgery. Their priority is in dementia, other forms of mental health, public health, social care. If you look more broadly, that is where there is a vast underfunding. Vast. I mean, social care in a rich country like this is a disgrace. A disgrace. It really is. That everyone wants it, but no one wants to pay for it.
People are quite happy to pay more tax for it.
Some are. But if you have a vote about it, you'll find the party says that won't get in. That's the sad fact. Because people don't have a realistic idea. They want to have Scandinavian-type education, pensions and health, and they want American-type taxes. Be one or the other. I think access to basic medical care is not a privilege, but some people think it should be a privilege. I don't. wealthy country should be absolutely fundamental, and access to reasonable education, and access to a reasonable pension. That's part of a civilized society.
Do you think people will understand, will rise up a little bit?
Slowly we just have to explain things better to people. Of course, we have to be more effective, we have to be more efficient, we have to cut waste. Yes, all those things have to be done, you're absolutely right. In the end, I think that you should be able to have free access to care. However, it may be that it's unaffordable. In the end, you may have to make a judgment that I'm going to save money for this particular condition, but what are you going to save the money for? How do you know what's going to happen to you? So, well, I've got all the money I need for 2 hips. Okay, well, suppose you have a stroke and you need rapid access treatment to treat this stroke, to make the stroke better, but it's quite expensive. You have a budget for that. So it's a kind of crazy. This was tried 20 years ago in Oregon and it didn't work. The Oregon, it's well known.
So early diagnosis of future problems in life.
Yeah.
That's a way of saving money.
Budgeting for the future. The future's unpredictable. But I think we're fortunate living in this society we do. In other societies, there's no way you'd ever get the treatment.
And what are your feelings about innovations coming from Asia or?
I think that, particularly from Asia, from India in particular, the electronic developments in India are fantastic. Miniature versions of echocardiogram machines, new apps on mobile phones. Doing medicine in sub-Saharan Africa, this is absolutely vital part of medical care. Going out into the bush and then sending photographs back to the hospital, advising on that what should be done. So, it's absolutely vital. And we're beginning to use this more. There are still very big problems we have to sort out, but there are 1 or 2 things that have happened which are dramatic. We have excluded smallpox. Smallpox was a ravishing disease in the 18th, 19th centuries. It's now gone. Actually gone. The organism sits in very high security silos in microbiology departments, because it should ever appear again, they need to be able to have the original there. Smallpox is eradicated. That's a fantastic thing. And polio is almost eradicated. There are 2 countries in the world who still have not eradicated polio. Those kind of problems are much greater than the things we do here. Yeah, so anyway, I think this is a very exciting place to work, and it's got some very talented people. That's what's interesting. And it's small enough that you know people.
Did you ever have to work on the South Block and North Block?
Yes, I've worked in South Block.
Did you have conversations in the tunnel?
Under the Fulham Road, yes, because all the chest medicine went on the other side of the Fulham Road. Yes, all sorts of weird extensions were made to that south wing. There was a shed on the 4th floor. The roof is very flat, and there was a sheer drop either side, the 4th floor. And when I say 4th floor, these are high ceilings, so it's a long way up. Not like an ordinary 4th floor, more like a 6th floor. And one of the cardiologists, a brilliant man, is now retired. He digitized echoes and kept echoes and did all this computer work in this shed. So you had to walk out across the roof through the rain and February into this shed where everything was stored. Those kind of things only happen in England.
Quirky.
Eccentric and quirky.
Very good.
But he made fundamental observations in echo and it turned things around,